Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I'm here with my friend, Dr. Ryane Englar today, and we are talking about her new book, Low-Cost Veterinary Clinical Diagnostics. Man, I get super geeked out about this. She's hilarious and amazing, and she may take over the world. Definitely listen to the end of this podcast when we talk about her struggles in finding laboratories that would work with her and ultimately working with a crime scene investigation unit. Only veterinarian type problems here. Only veterinarian type problems. So anyway, she is incredible. This is such a fun conversation about the basics that we have put down and forgotten in vet medicine, about using sight, smell, sound, feel. I don't want to say taste, but you knew I was thinking it. It's all of those things where we've gotten pretty dependent in a lot of ways on our fancy diagnostics, and they're great. They are wonderful, but boy, there's some value in really just using our eyes and having experience and looking at samples. And is it possible that we could be extracting a lot more knowledge from just the most basic tests? Yeah, I think probably so. I'm curious what you guys think. But anyway, you just check this out. It's such a good conversation. She's really got me inspired to start looking at my game and figuring out where are the simple little holes in my basic knowledge that would make me a better vet and that would help me take better care of pets with basically no cost to the pet owners, just looking at what we're already doing and getting a little bit more out of it. So anyway, guys, fun episode. Let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Ryane Englar. How are you?
Great. It's good to be here. Thanks for having me.
Oh, always enjoy you. You've been on the show before, and I was thrilled to have you back. And I wanted to have you back because you have a new book out. For those who don't know you, you are an associate professor and executive director of clinical and professional skills at the University of Arizona's College of Veterinary Medicine. That is a long title. And you're an author. This is not your first book, is it?
No, this is number 11 if you count the ones that I've been partners on.
Not quite the first book, no. But yes. So you have a brand new book out called Low-Cost Veterinary Diagnostics. And I was like, that's an interesting title. And I love that you have a book on this. Why don't you just go ahead and, so I want to open this conversation up and basically just sort of say, tell me at a high level, tell me what this book is about. Let's just start there so that I'm not picturing something in my mind that's not true.
Yeah, absolutely. The book started out, the original intent was to develop a clinical skills guide or manual for our students, really with respect to blood diagnostic test, urine, and fecal results. But then it quickly expanded into what it is today, which is really a tool that can be used by vet students, new graduates, seasoned graduates, veterinary members of the whole team, so vet techs, really even clients for some degree. And what it is really looking at what are the tests out there that are point of care that we use each and every day, and how can we maximize the data that we obtain from them, right? And the classic example I'll give from vet school is that by the time I got to fourth year vet school, the internists or a generalist on any service would say, here's a patient, here's the vignette, tell me what test you're going to run, right? And I graduated from Cornell University, very proud to be a graduate there. But every answer for every vignette was, we need a CBC, a chemistry panel, a urinalysis, 2 to 3 view chest rads, an abdominal ultrasound, maybe an MRI. So quickly it expanded, and that was right, the gut reaction of like, that's what they want to hear, good. But we quickly lose sight sometimes of, and I learned that as an educator, why are we doing that, right? If we're going to ask a client to run a test, what do we need that for? What are we looking for?
Yeah.
How are we going to interpret it? And so there's a lot of information we forget. So the book was born out of what can we get and drill down and get the max out of a PCV, right? There's an entire chapter on assessing the color and turbidity and smell of urine, right? A chapter on fecal consistency, fecal color, fecal odor, really looking at expanding that tool set so that if we are in situations where we have to scale back, what can we do? And really, let's not feel bad about scaling back. Let's be like, yeah, let's get the most out of this data, whether that's blood, fecal, or urine testing.
That's fascinating. I really love this. This is a lot of the mentors I had in medicine they're much older than me, right? I think that's often the way that it goes. And you kind of come in and they're at the sort of the end of their career and they've got so much experience and so much knowledge. And there's a couple of them, Dr. Mikey Scher pops to mind. And that guy didn't seem like he needed any diagnosis. He could just feel the pet and say, I think it's probably this. And darn if he wasn't right all the freaking time. And you always wonder, like, that stuff is so powerful. And he would just beat the drum on, he would ask you, where do you want to start? And the answer was the physical exam. And if you said a bunch of stuff, he would shoot you down, which is rare because most people would say exactly what you said, which is, we're going to need this litany of tests and this big workup. And he would say physical exam. And then basically he'd be like, and then we're going to see what we have. And then we're going to make a plan from there. And he was so good. He was that guy who could walk in to the treatment room and he would sniff the air and point at a pet and go, that pet has parvo. And he was right. He was like, that one right there, that's got parvo. And just, it was incredible. And so I really love sort of where you're coming from. Where do you see, so I guess, let me say this. If veterinarians, if vet technicians had more of this type of knowledge, right? And were more comfortable just using their eyes, their ears, their nose and their touch and sort of looking at patients and looking at samples this way. Where do you see the biggest areas of potential impact in taking this approach? What are things that you see that we're just, there's such an opportunity here and we're not pursuing it? What does that look like?
Yeah, absolutely. I think for me, really, it's a matter of spectrum of care, and it's really looking at cost for factors. Obviously, looking at how can we partner to create a tailored treatment plan and diagnostic plan for a patient who may not be able to do the litany of tests. So that's kind of the first easy pass. When you look at the title, you say, "Oh yeah, that's what it's about," right? When I can't do everything. But then if we put that to the side and we think about it on a deeper scale, how do we actually create that partnership and communication with our client of putting that plan forward? So if I'm going to convince a client to do test X, Y, or Z, I really need to make a case for why and what information am I going to get out of there and what am I going to do with that information? So we have to have not only the plan, but the expectation of if I do this and I find result X, Y, and Z, how will that actually allow me to better treat your patient? And so I think it opens up those communication windows. It allows questioning, which I think sometimes we get that defensiveness of why is someone questioning why I want to do this certain test? And it can say, oh, well, let me tell you why. Like, let's have that conversation about what is my hope for this pet so that we can actually make it custom, so that we can apply what we need and the knowledge we have for pet-specific care.
So one of the things I like a lot about you, and is one of the reasons I first really wanted to talk to you, is that, as a professor of clinical and professional skills, you kind of walk this line between a clinical approach and then also a communication aspect, which is kind of the things that I'm most excited about. I really love vet medicine from a challenge standpoint of knowing what to do medically, and then also being able to sort of communicate, negotiate, advocate for the pet, like build a relationship with the pet owner and kind of get them on board. How does an approach like what you're talking about change the way that we communicate with pet owners? I mean, is it a different type of do you break these out and you're like, suddenly are you pushing more to say, let's start with a PCV and then we'll run a full blood panel, based on what we see, or do you go with a full blood panel and just extract extra amount of information? Like, how do you parse that, I guess? And then sort of how does that really, when the rubber meets the road and you have these skills or you have this focus on really looking deeply at what we're doing and extracting the most information possible out of it, how does that change the way that you communicate?
Those are all great questions, man. I wish we had like 22 hours straight on this podcast. So everybody get some popcorn, sit down. It's going to be a while. No, I'm kidding. I think the hardest part, right, is it does depend on the patient. It depends on the presenting complaint. And ultimately, there's immense value and wealth to doing some of those more advanced diagnostics. So in an emergency situation, I may be more apt to opt for full panels. But I think where it really helps is in situations where we may want to do everything, but can't. There's a limitation. Maybe the limitation is cost. That's the most obvious. But maybe the limitation is we might not have the equipment, right? Maybe we don't have every upgraded coagulation panel profile we need or would want. So we have to scale back and we have to say, well, what can I do now? Maybe it's a weekend and our machine is down and we don't have the ability to get what we need, even if the client could afford that. And so I think it's saying, what can we do? And having a transparent conversation with the client, right? This is what I would like to do and why. And then it becomes a dialogue. And when that owner, which we've all been in that situation, says, I'd love to do everything and I can't because at X, Y, or Z, cost is often a factor. Okay, let me prioritize. This is what I want to do. And this is actually how I can get the similar information, right? It may not have every single panel item that a chemistry profile would, but this is what I'm going to do. And with this test, I can run out X, Y, and Z. And I think a great example, right, is the blood smear. The blood smear, I remember in clinical year, every single case that walked in the clinic, it didn't matter how the blood was run. You had to run as a student many blood smears that we went through, 10 and 15 and 20. We were so bad at creating them. But by the end of that fourth year...
It wasn't that we went through them. It was just that we were so bad at making them. Personally, I would take a dozen slides to get one that I was comfortable showing to another student. Like, oh, this is
That's
mine.
An A+. I went through like 100 and then Cornell probably flagged me. It's probably in my system in some record somewhere of all the boxes I went through. But, that blood smear, right? So in school, we got used to looking at it. And
I leveraged my technicians that way. That was my workaround. Was I never got good at it. I just go, leverage your technicians. Not because I can't make a blood smear. That's not why.
Right.
But because I value them. That's why I let them do it.
And you know what? They're the ones who soar in our clinical skills lab, teaching our students how to do it. So I'm all for that, right? I think where we get weak is we forget to look at those blood smears or have someone who has skill look at them, right? True. And so days go by, weeks, years, and I'm cringing to say it, but there were many a day in private practice where I need that. I'm going to look at the automated analyzer.
Yeah.
Then we forget,
I think that's really
right? We forget.
I mean, I think that's really defensible. You know what I mean? Of like, we've got these awesome analyzers and they do all the things. And you know what I mean? And you go, why do I need to look under the microscope when I've got this beautiful scatter plot that lays out all of the things? You know what I mean? And like, as we have artificial intelligence, there's just, it gets easier and easier. I think in life in general, it's getting easier and easier to be a little bit intellectually lazy. Of just being like, you know what, like, let's just pop in the computer and see what the readout comes. And I know that there's a downside to that. I feel like there's a downside to that as far as our skin. I think we all really want to be, James Harriet meets Crocodile Dundee, who can just kind of, like bush medicine where if there was, we take great pride as a profession in how well we would do in a zombie apocalypse. I don't know if you've noticed that, but there's a lot of people.
All the memes out there.
Yeah, there's a lot of memes. There's a lot of people who take great pride in how well they think that vets would do in a zombie apocalypse. And those are the people who need to buy your book. Like, I'm like, if you think you would make it, you should have this book because this is how you'll continue to practice after the zombie apocalypse. And I sort of a bit of a digression, but it's just to say I feel it's almost like it's easy just to spend more and more time on the couch. If you have a more and more comfortable couch, it's almost like we have a more and more comfortable couch in a lot of ways with our diagnostics and stuff. And you go, boy, the ability just to look at the blood smear, that's real. Like no one can take that away from you. And man, what a useful tool in your toolbox. And I can tell you, I am 100% guilty of just look at the scatter plot. You know what I mean? And just going, let's see what we got here and go on.
It's absolutely me too, right? It's easy. Like you said, I think that's a perfect analogy about the couch. And so then what happens, right? We get the case where we can't get that scatter plot and then we feel frozen and paralysis, right? And so having that ability to say, all right, let's keep those skills fresh. We have a whole chapter in looking at the Buffy coat, right? And how many times have I not looked at the Buffy coat in practice? And I'll be honest with my students. I'm like, you know what? This textbook reignited a fire in me because it taught me the areas I got lazy or the things that I forgot, right? Or the things about the urine dipstick that I just took for granted. And then I realized, oh, that's right. There's a certain cleaner I cannot put in cat cages or dog kennel cages. Then an animal pees in the kennel in the hospital. I can't just put the dipstick on that surface because it's contaminated. And now it's going to cause a false positive or negative. And so it has really cool little tips and tricks and pointers. My co-author was amazing, Dr. Sharon Dial. She's a clinical pathologist. So she filled in all the gaps that I had forgotten. So it was a learning experience for me. That's what we hope. It's really a celebration, I want to think about it, not a critique or criticism of all the immense wealth of diagnostic testing we have. That has a place forever in my heart. I respect it. But it's looking at what else is there? Let's celebrate what we can do when we are in that apocalypse, as you say.
Oh, yeah. If you dream of doing team training with your team, getting your people together, getting them on the same page, talking about how you guys work together in your practice, I'd love to help you. You can check out drandyroark.com and check out the store. I have 2 different team training courses. These are courses for teams to do together to get on the same page and to talk about how you do things. I have my Angry Clients course and I have my Exam Room Toolkit course, and they are both available and there. Check them out. All right, guys, let's get back into this episode. Well, I like this a lot. I've been thinking a lot about artificial intelligence recently. So like the ChatGPT stuff, I think is really interesting. I think it's going to fundamentally change medicine. It's definitely going to fundamentally change the way we interact with pet owners and the knowledge that they come with. I mean, these are big changes and they are right around the corner. And I look at that. And I do think a lot about how it's going to interact with us. And I don't think that like artificial intelligence is going to replace practitioners. I think we need to adapt around it a bit so that we say we have these AI tools that are great and amazing. And also we should be just rock solid on the fundamentals and so that we can leverage them to the maximum potential and know how to use them and still be entirely relevant and be confident and comfortable, in our skin and in our role as the healthcare provider. And so this book just really hits on that for me. I imagine what it was like sort of writing this book. And to me, you explained sort of checking yourself and sort of finding these areas. And to me, I think that would be the most fascinating thing, is I'm sure you sort of had these discoveries and unlocked these things that go deeper maybe than you had in the past. And you're a very accomplished veterinarian. You're boarded by the ABVP and you've been teaching this for a long time, but were there areas when you started to kind of dig into the research for this book, or were there things that really unlocked for you? Were there areas that you were surprised by how much depth there was that you either weren't using or weren't really aware that you could get information from?
Yeah, great point. I would say every single chapter, right? I think that especially the ones that I had to write, and then Dr. Dial would go over them and we would sit side by side. Because each one of us would either lead a chapter or be the buddy up and help. And I think that for me, much of it was checking the knowledge that I knew and where did it come from? Like so many things in life, right? You have this saying or a motto, or you're like, I learned this 8,000 times in vet school. It has to be true. And then you write the book and you're like, is that real? Did that actually happen? Is that true? Did I make that up? Right? Did someone else tell me? And I just assumed that it was true. So I think for me, as with every book writing experience, just the literature review, finding out, oh yes, that actually is documented and this is where it came from, is so helpful because then it does check yourself, right? Is what I'm telling the next generation truly right? Or is it because I remember someone somewhere in my past told me to believe it? And I just accepted it.
Were there any examples that come to your mind of things that you were like, oh no, this isn't true?
Gosh, I wish, there probably are thousands of them. I think for me, it was just the reminder, right? When we were going through, I'm stuck on the same Buffy coat example of going through. And when Dr. Dial and I reached and wrote the table of contents, right? I filled in what I knew. And she's like, maybe we should do a Buffy coat chapter. And I'm like, what? The Buffy coat?
Yeah.
What do I know about that? Like,
Yeah. When you said that, that was
I
the
know
experience
what
I
it
had. Yeah. When you said
I'm
that was
like,
the exact experience I
oh.
had. Was like, oh, the Buffy coat.
Yeah.
What do I know
Or,
about? Not much.
Right? Or total protein, right? Again, and I love to tell my students this because sometimes I think they just think I know everything. And I'm like, oh no, that's why there's a library in my office. Like I need to reference stuff. Total protein, right? As a vet, I know how to get it, right? Or my technicians use the refractometer, they get the value, they give it to me. I can interpret it, but how much do I really know deep, right? I can give you the differentials, high protein, low protein, but everything's unpacking more and more so that it's not just a one sentence answer. It's let's dig deeper beneath that. And other areas of the book made me want to explore more. For example, you mentioned parvo, right? And smelling the smell of parvo. And for me, the chapter on fecal color, odor, consistency ignited my spark in another crazy area of my brain, which was why do clinical skills labs like the ones I teach only focus on visual things and tactile things? There's zero olfactory clinical labs in vet med and not in human healthcare. In the military, yes. So I've spent 3 years trying to create diagnostics work to develop olfactory cues that we can actually bring into the classroom. So in another 6 months,
yes, you came up with a stink test.
Okay. Yeah, so I'm working with a crime scene investigation lab on that. And they're the only ones that would take biosamples because, believe it or not, in my crazy quest, I found that most of the companies that use mass spectrometry to evaluate scent are food companies like the cereal companies, because if clients are like, my cornflakes stink, like it smell like mold, we got to fix this, right? So they go to these labs. Well, I had lots of talks with these labs. They were wonderful people. I thought I was very clear about we have fecal samples from dogs. And then we reached a point that was pivotal on every call. Wait a second, you would have sent fecal samples to my cereal lab. No, we're not doing that. We're not contaminating. So many doors got shut down, right? I had them sold and they're like, wait, we're not actually. So I finally found the crime team investigation people, and now we're hopeful. But
this is amazing.
That's huge, right? So maybe in 6 months, I'll have that. I think the biggest downside is where are we going to test that? So nobody wants to be the guinea pig in our faculty suite office to test the parvo scent.
Oh yeah, you have mad scientist problems. Did you know that? Like you run into the problems that great inventors like Dr. Frankenstein have run into again and again, which is people closing doors in your face, asking what you're doing with a dead body, things like that. I love that you have a crime scene investigation team who's like, yeah, we'll talk to you. That makes me so happy. What does a stink lab look like? I don't know if that name's going to stick. I don't know if you like it, but to me, Ryan runs stink labs. What does this look like? Help me understand like what this would even be like. I'm assuming that the olfactory stuff is hard because it's hard to quantify, and say, oh, this is a 5. This one's a 5. I don't know how you do that with a smell. But yeah, seems pretty sort of subjective. Help me understand, like what does that look like from a training standpoint? I think it's fascinating.
No, that's a great point. Basically, what we're looking at is we have to find the olfactory fingerprints of different disease processes in biosamples. And so parvo seemed to me the easiest starting point because it smells bloody, right? There's this metallic component. If you poll all of us, there's this heme component coming from the blood. And so my hope was we could find that compound in it. So you have to actually take a sample, pulverize it. There's lots of ways to do that. And basically it has to run through a very fancy mass spectrometry machine. That's going to spit out a little pattern, we hope, that can differentiate normal diarrhea that's not parvo positive from diarrhea that is parvo positive. So the hope is by by going through enough samples, you can find the blueprint or fingerprint. So once you find the fingerprint, we now can identify what those compounds are, and you can put them together, kind of like a perfume factory, into one little concoction. And it could be liquid or it could be infused on like a little pad, kind of like those scratch and sniff stickers that probably aren't allowed anymore that we used when I was a kid. They're probably very toxic, but I haven't seen them for a while to buy them for my niece. So something sketchy about that. But the idea would be we would then be able to build that into a lab. And so the example I have, and it's the only one I've found when I was trying to figure out how to make this possible, I get a lot of simulation catalogs, and I found one from a nursing program, and they had a fake vomit. And they wouldn't tell me what was in the fake vomit. They said, you have to buy it. And
it's proprietary.
Yeah, it's proprietary. Buy it and call the manufacturer. So I said, all right, great. This was pre-crime lab. So I order it. It arrives by FedEx. Well, I'm teaching another class. Everything comes to this main depot. And all of a sudden, students in my lab are like, is somebody really sick in here? Right? We're in a classroom down the hall. They're like, somebody threw up. I don't know where that's coming from. And all of a sudden, a whole bunch of students run to the bathroom. They're like, we feel really ill. Somebody comes down from the main office. They're like, Dr. Englar, there's this package up front and it really stinks. And they hand me like this box, and it had been like crushed by the FedEx people. I love FedEx, no offense, but it was crushed. The whole thing was leaking, this fluid in the whole building.
Mad scientist problems. That's what this is.
People were like, don't do it, Ryan. So now I'm going to have to do my test outside in Arizona because everyone does not want that. But especially after COE comes to visit, right? We don't want the accrediting bodies turned away. But my thought would be, if you can do this, Parvo is our first pilot. It's very expensive, and I have no grant money external to do it. So we have to do very few samples and hope for the best. Then we could do things for the ketotic breath. You could do all kinds of different aromas, right? Pseudomonas for otitis, right? That horrible rancid smell that we all kind of know. And then we're like, we need to culture this year. That's rank, right? It would be great to be able to recreate that. And it's very Jekyll and Hyde. So maybe my love of Broadway musicals has inspired it. But things like that make me want to come to work, right? Want to create things, because if we can do that, then we know what, like, if you can just train someone to recognize that smell, but think about the utility in every other area. So if we forget just diagnostic, think about individuals that pass out in surgery because they smell a cautery and they just need sensitization or desensitization, or people who pass out because the smell of items in necropsy or the sight and smell of blood in surgery, right? If you could partner with psychology departments and actually help individuals, maybe you could be the next neurosurgeon, but there's some kind of a gap because blood smell makes you feel sick. So let's recreate all of that, have its own little lab, and figure out a way to get people to do what their strengths are. So I'm always thinking about things.
Well, I'll tell you, I'll help you out right here. So I do escape rooms with my wife. And so we always go, and we love them. And so anyway, we did an escape room, and there were these little metal containers, and they all looked identical, except they had little holes punched in one end. And then there was this door, and it had a little tray on it. And there were like little symbols of different, herbs and things like that. You would kind of sunflowers and things like that you would recognize. And the idea was you were supposed to smell these containers because they had a scent inside. And then when you put them onto the tray in the right order, the door would open. And I was just thinking that could be like your exam. And when they put the things on the tray, the thing unlocks and they can leave. They can go home for the day and they're done with lab. And so I don't know. I just sit with that a little bit.
Yeah, I love that idea.
I just put it in it's less mad scientist than you usually go. But
I could tone down a bit for you. I could make that work.
Or tone the door up a bit. I don't know. We can get, I'm sure you can find a cursed door from an old temple, something like that would impress your colleagues. Anyway, Ryane, thank you so much for being here. I'm going to put a link to your book down in the show notes. Where can people find you? Where can they learn more?
Yeah, absolutely. For this textbook, it's published by Wiley-Blackwell, so you could go straight to the Wiley-Blackwell website for your country, right? The U.S., but there's also European versions of that. And you can buy direct from Wiley-Blackwell. If you're an instructor, I don't know what the stipulations are, but there's a link where instructors could request a free copy to look at, right? If you were thinking about incorporating it into your classroom. So that's the best reason to go to the Wiley site. Others, my students get a free access to the University of Arizona because we have an ebook user license that's unlimited. But other students from other universities can go to Amazon.com. Sometimes you get a price break depending on how they do those algorithms. So I also have an author page on Amazon.com. So you can also link to not just my other Wiley-Blackwell textbooks, but also my 5M textbooks and soon Taylor and Francis and Elsevier.
Awesome. I'll put links in the show notes. Thanks for being here. Thanks for listening, everybody. Take care of yourselves.
Thanks so much. Appreciate it.
And that is our episode, guys. That's what I got for you. I hope you enjoyed it. I hope you got something out of it. Thanks to Ryane Englar for being here. Gang, as always, if you enjoyed this episode, share it with your friend or leave me an honest review wherever you get your podcast. That is how people find the show. It really means a lot to me. I always love it when people leave nice positive reviews and pats on the back and things like that, or even constructive feedback of things you'd like to see more of or things we could do differently. Anyway, guys, take care of yourselves. Be well. I'll talk to you later on. Bye.